Hi, my name is Kylie Bartram. I'm a private practice dietitian and PhD candidate here at Griffith University. If you need to contact me, my details are on the screen there. Today we'll be discussing the online module of hypertension. So I know that you've previously covered hypertension very briefly in the online module of CVD, but today we're going into a little bit more depth. So an overview for today's online module, we'll be going through the definitions and types of hypertension, how to measure blood pressure, etiology, the diagnosis, risk factors of hypertension, the signs and symptoms, as well as medical and dietary management. So what is hypertension? It's also known as high blood pressure. So just a bit of a review from your first few years of courses. So what is blood pressure? Blood pressure is the force of the blood pushing against the walls of the arteries as the heart pumps blood. So hypertension is where this force becomes too high. And we have two measures that make up hypertension. So it's the blood pressure when the heart pushes blood out of the ventricles, which is systolic. And then we also have the diastolic, which is the blood pressure when the heart relaxes and the ventricles refill with blood. So it's the coming in and the going out. So there's two types of hypertension. So the first type is primary, also known as essential hypertension. This makes up for about 80% of all cases. And we don't actually have one identifiable cause of hypertension, of primary hypertension, and it's considered multifactorial. So it could be due to hormones, electrolytes, fluid balance mechanisms. And it often gradually develops over many years. The other type is secondary hypertension. So this is the outcome of other diseases such as renal, liver, endocrine, or drugs and alcohol. And it tends to appear suddenly. So how do we measure blood pressure? This should be a bit of a refresher from your first few years. So if you remember, we use either a gauge, stethoscope, or an electric sensor and a blood pressure cuff. So we use the cuff to create pressure in the arm. And then once the pressure in the cuff begins to release, that's when we hear the first sounds coming in, which is known as the Korsakoff sounds. And that's when we take the reading of systolic pressure. Then when those sounds disappear, that's when we take the reading of diastolic pressure. I just also wanted to touch on measuring blood pressure. So this is an image directly from the guidelines. I just want to highlight there's actually a fair bit involved in when we're taking blood pressure, and there's a few different important considerations, such as having a quiet room with a comfortable temperature, no smoking, coffee, exercise for 30 minutes prior, an empty bladder, relaxing for 3 to 5 minutes, taking 3 measurements at 1 minute intervals, but then only using the last 2 and the average of those 2. And then also considering the position of the person you're taking the blood pressure from. So I guess this is important to highlight when a GP would be taking blood pressure and making sure that this is what actually happens, and even potentially checking in on how the client had their blood pressure measured. So what is the diagnosis of hypertension? So to diagnose hypertension, the GP will take 2 or more blood pressures on 2 or more separate occasions. They might also take ambulatory blood pressure monitoring, so that's regular intervals over 24 hours, which gives it a more accurate picture. So by doing this regular blood pressure over 24 hours, eliminates the white coat effect. And if you remember the white coat effect from previous years' lectures, the white coat effect is where we see a marked increase in blood pressure when you're at the GP. Essentially, they think this is caused due to the environment and pressure within the GP clinic. So the diagnosis and classifications of hypertension, just briefly going through this. So optimal is your systolic under 120 and your diastolic under 180. We still consider 120 to 129 of systolic and 80 to 84 of diastolic within the normal range. The high normal is 130 to 139 with the diastolic of 85 to 89. Then we see the other types of hypertension. So grade 1, grade 2, grade 3. It should say mild, moderate and high hypertension for the different grades. And we can see the different readings here. So touching on the risk factors for hypertension. So age, so we know that 45 years is approximate age. We see a lot of hypertension diagnoses. Men are at greater risk of hypertension. However, when a female turns over the age of 65, that's when the risk is quite even between men and women. This is because they think that estrogen actually provides a vascular protective effect in premenstrual women, and of course estrogen levels fall when they go through menopause and postmenopause. Ethnicity, so the Asian population and also Hispanics are at higher risk of hypertension. Family history of hypertension, being overweight or obese, not being physically active, smoking, excessive sodium in the diet are all risk factors increasing the risk of hypertension. Other risk factors include too little potassium in the diet. So if you remember back to pathophys days, potassium works by promoting sodium excretion through the urine and helping blood vessels relax. Too little vitamin D. So this is an area of a lot of investigation at the moment, with some studies suggesting people who have high blood pressure tend to have lower levels of vitamin D. Excessive alcohol intake, stress. We talked about certain chronic conditions, previous diagnoses of kidney disease, diabetes and sleep apnea. Also, we can see hypertension in pregnancy. Also, we can sometimes see a higher blood pressure when an individual is dehydrated. So I just thought I'd quickly pop this up. So this is substances and medication that may influence blood pressure. So if we think about the secondary hypertension, you can go through this list, but we have some medications here and also some over-the-counter supplements, such as caffeine-containing products and energy drinks. So this may be a careful consideration that you may take when collecting the diet history. Moving on to signs and symptoms. So with hypertension, most people will have no signs or symptoms. Symptoms aren't specific and they don't occur until the blood pressure has reached a severe or life-threatening stage. But again, some people can go without any signs and symptoms. Those individuals who do get signs and symptoms from high blood pressure, they often experience headaches, shortness of breath, nosebleeds and dizziness. Now, briefly touching on some complications. I know Liam has previously gone over some of these, so I'll just briefly discuss them. So when blood pressure is uncontrolled, it can lead to most commonly heart attack or stroke, aneurysm, heart failure. Can also result in the weakening and narrowing of blood vessels in your kidneys. If we think about physiology, it can also result in the thickened and narrowed or torn blood vessels in the eyes. Hypertension is also one of the inclusion criteria for metabolic syndrome. It can also result in trouble with memory or understanding, obviously, if you're seeing this person in a clinical setting, you want to question whether either signs of dementia as they present the same. So moving on to hypertension medical management. I don't want you to know this slide too well, but I just thought I'd put it up because it's quite interesting to identify the places where your role as a dietitian may come in. So this is from the guidelines for GPs. So to check, they're going to check their eligibility for absolute cardiovascular risk. So you can see at all levels here, they promote lifestyle of ice. We commonly see, I've previously seen a lot of patients in this diagnosis area, so under 60 to 100. So if it's slightly below, if the systolic is slightly below that, then they'll encourage the patient to see a dietitian and get their blood pressure under control. They've often got a 2-month time frame to get that under control. Otherwise, they're often threatened or told that they will have to start medication if they can't get it under control. We'll also see them once they've commenced drugs or just for a check-in later on. So again, briefly going over the medical management. So we've got a number of drugs. Hopefully you remember these from from pharmacology. So we've got the first GNT, which its action is venous and arterial dilation, so it lowers blood pressure by dilating the coronary vessels. But you also want to note the side effects here, and then these are some names, so glycinate and nitrolingual spray. So you can see, you often see when people have this, they will spray it under their tongue. Commonly used one is beta blockers, so it just reduces the heart rate, which then in turn assists with the pressure. So a common one is propanol. And then here we obviously have some side effects, so we can actually potentially drop it too low, so that's something you want to be mindful of. Calcium antagonist, so it's again another dilator and an antihypertensive, and it also alters the heart rate. Again, some drugs here and also some potential side effects. So these are just a few drugs that I want you to know, but and keep in mind that you might see these when treating someone with hypertension in a clinical setting. Continuing on, less likely but still happens, diuretics, so acts on the kidneys to help eliminate salt water, reducing blood pressure volume. Reducing the blood volume, which in turn will reduce the blood pressure. We've got some side effects here. Aldosterone antagonist, so that just reduces the salt and fluid retention. And we also have the ACE inhibitors, which help relax and dilate blood vessels. Again, just being aware of a few drug names and also some side effects. Lastly, we've got angiotensin II receptor blockers, so that's venous and arterial dilation, which lowers the blood pressure and dilates coronary vessels. Renin inhibitors, so slow down the production of renin and causes vasodilation. And we also have the central acting agents, which prevent brain from signaling to the nervous system. So these eventually will assist in managing hypertension, but the ones earlier on are probably the more commonly used ones. So if you remember some of these terms from pathophysiology and other subjects, it might be good to have a bit of a look at the pathway of these different systems and mechanisms, and look at how where these drugs interact. So where do we come in? So this is the lifestyle modifications to managing hypertension. So eating a healthier diet with less salt. So we have the DASH diet, which I'll discuss more in depth soon. Also, the Mediterranean diet is gaining traction. Encouraging the patient for regular exercise. The GP might suggest them to quit smoking. Limiting the amount of alcohol. Aiming for a healthy weight. Practicing relaxation or slow deep breathing, and controlling blood pressure during pregnancy. So briefly mentioning the lifestyle modifications for managing hypertension. This is one of your readings to be done after this online module, but this is a table directly pulled from the hypertension guidelines. So you can see the different factors that they've discussed, so physical activity, weight control, diet, smoking cessation and alcohol intake, and then they've found this information and directly pulled it from previous guidelines. So you can see on the right hand side that they've got the exercise targets from the Australian Physical Activity and so on. So just a brief to be aware. So now we're going to touch on sodium and salt. As a dietitian in practice, this is probably one of the best strategies, or the first line strategies I guess we could use to reduce hypertension. So if we look at a high-risk individual or an individual who has hypertension, we want to ensure that they have less than 1,500 milligrams of sodium per day. And if it's a healthy individual, we want it less than 2,300 milligrams per day. This table here is from Vizan's, and I just wanted to highlight how much salt is actually in our food. So these foods here are all commonly consumed foods that you may see in practice. So if we have a look at white bread, for example, say 2 slices, it's about 100 grams. So that you're already looking at about 456 milligrams of sodium. If we have some butter of that, say per serve, we add 55 milligrams. And then say if we have a coffee with full cream milk, again, if we have about 100 grams, that's about 36 milligrams. So if we calculate that all together, just at breakfast, this person's already having about 550 milligrams of sodium. And that's if they just have 2 slices of bread, which commonly people also have some breakfast cereal as well. So you can see that how quickly our sodium intake can increase. So we also have some evidence-based diets to assist in hypertension. So the first one, which I think is briefly being discussed in Liam's lectures, is the diet approaches to stop hypertension, also known as the DASH diet. So it emphasises fruits, vegetables, whole grains, poultry, fish and low-fat dairy items, replacing saturated and trans fats with poly and monounsaturated fats, decreasing the salt in your diet, which I've previously discussed, omega-3 fatty acids, so recommending regular consumption of oily fish, and recent studies have also shown that fish oil supplements and flaxseed may also be of benefit, but more research needs to be done, and also ensuring adequate fibre. So you may do this through psyllium and wheat bran. So it's important to emphasise that in a previous study who looked at participants who completed the DASH diet and compared to healthy controls, it lowered their blood pressure within just 2 weeks. And if we think of the overall principle of the DASH diet, it encourages the reduction of sodium and to eat a variety of foods which are rich in nutrients that may help lower blood pressure. So nutrients such as potassium, calcium and magnesium are all nutrients that may assist in reducing blood pressure, which we've previously discussed. Just briefly going over that next diet type, so that's of course the Mediterranean diet, which is continuing to gain more and more traction, and we'll probably see this as a regular part of our practice. So as you can see, the Mediterranean diet pyramid here. But just briefly, one study compared both the Mediterranean and the DASH diet, And they found that they're relatively similar. They're both easy to adhere to and they're both palatable. They both have recommend a high intake of fruits, vegetables, whole grains, nuts and unsaturated oils, and also recommended the reduction of red and processed meats. So this is in accordance with recommendations of cardiovascular health. The main differences between the two is that the DASH diet is more suitable as it recommends lowering your sodium intake, which is not a feature of the Mediterranean diet, and also that the DASH diet includes more protein, which it has quite an emphasis on poultry and fish, and also emphasises the consumption of low-fat dairy products. Moving on to more specific nutrients or foods. So the first one was folic acid. So one study suggested, or a few studies have suggested that it reduces blood pressure, and they think that this is due to reducing or helping the blood vessels relax and therefore improving blood flow. Also some other supplements or products. So these supplements or products increase nitric oxide or widen the blood vessels, so they're dilators. So similar principles to the folic acid. So magnesium increases the production of nitric oxide. We have cacao, beetroot juice, which both increase nitric oxide or have on nitric oxide. Other supplements or products are coenzyme Q10, L-arginine or garlic. So again, these are foods that potentially may assist in reducing blood pressure. Just briefly documenting the guidelines that I've been referring to. So the first one is our national guideline, which is the Heart Foundation, and then there's also been a new international guideline, which I recommend you refer to. Looks like we've lost some references there, but I just wanted to highlight some potential resources I've used in practice for hypertension. So the first one is the Baker IDI, the High Blood Pressure and Salt resource, which is a fantastic resource that goes through a number of different things like making your food still flavoursome and label reading. The other one is the Nemo Low Salt resource. Again, goes through a lot quite in detail on changing to a more low salt diet. And the last one is quite a nice pictorial guide of simple swaps to eat less salt. So that's all for today's online module. It will now be followed with a case study.